Came.
Cheese.
Alrighty, we are going to go over secondary assessment and reassessment and then go into critical thinking. This is a long chapter, but a lot of this stuff is review. Everybody has their clickers. I did a lot of stuff clicker-wise, so that way we can kind of rush through it. There is some information in here that, like I said, is review. Okay, it's probably national standards. I need to cover it because for some of you, you've been out of school for a while. Others just were in advanced EMT last semester. But there's a lot of you who have been out for at least a semester or a couple. So it might be a little bit more helpful for you. All right, get your clickers ready. In a secondary assessment, what type of data is retrieved by the paramedic? Is it objective data or subjective data? Aren't you proud it actually worked for the very first time? Thank you. I appreciate that.
When do you learn to do stuff?
I don't get a cookie? I'd rather have a cookie than a star. I like to eat. Can't you tell? I like cookies, but I want stars. A sticker first. All right. Is that everybody? Woo! All right. Let's talk about the difference between subjective and objective data. What is subjective data? What the patient tells you. It's nothing you can physically see with your eyes. You can't see that they're having chest pain. You can't see that they're nauseated. All right? You can probably see that they're short of breath. And you can see that they're vomiting. You can see that they're diaphoretic. That sort of thing is objective data. What the patient tells you is subjective data. And what you can see with your own eyes is objective data. So when you are getting information from a secondary assessment, that's what your findings are. You're doing a full head-to-toe assessment. What you're finding is your objective data. Does that make sense? So the data retrieved in secondary assessment is objective data. It's very important that you know the difference between those two, because you will have questions on your test to be able to tell me which one of these is objective and which one of these is subjective. Does everybody understand that? Say. Subjective is what they say. That's a good way to remember that. Objective is what you observe. Subjective is what they say.
Secondary is not subjective.
I have a question. Tell me if I'm wrong. Don't we do our OPQ and our RST and our sample and all that in our secondary?
That's considered part of the primary assessment that we talked about the other week. Remember? We did the primary assessment. We did their ABCs, and we went into gathering some history. Most of that is in primary, considered in primary assessment. I see what you're talking about because if you look on your checkoff sheet, it kind of says secondary assessment, and then under that, it's got your vital signs, it's got your sample, and your OPQ-RST. But mainly for secondary assessment, it's your assessment of the patient, it's your physical, hands-on, full head-to-toe assessment. That's a really good question. Anybody else have a question? All right, it consists of two elements. You got to obtain vital signs, which is objective data, right? The patient can't tell you their blood pressure is 100/70. You have to take that for yourself, right? Vital signs also include a blood glucose check. Everybody always forgets an AccuCheck. But AccuChecks are considered part of your vital signs. And then the next part of the element that's part of the secondary assessment is your full head-to-toe assessment. Yes, Hayden?
Do we use blood with an AccuCheck?
Yes, you do not use cerebral spinal fluid. Smart tail. I'm so glad that lecture did not have any volume. All right, here's another question. Will every section of the secondary assessment be performed on every patient? Will you do a full head-to-toe assessment on every patient? Yes or no? Pick one.
Do we want the book answer?
We go by national standards, so yes, it would be the book answer. All right, that's everybody. Either some of y'all are just clicking, or some of y'all really don't know. All right, so why would you do a full head-to-toe assessment? What kind of patient would you do that on?
Everyone.
A medical patient that maybe has unknown origin? Like you wouldn't do a full head-to-toe assessment on somebody having chest pain, would you? You would do a cardiac, a respiratory, a neuro, and maybe a skin assessment. That's probably the only ones you would do. You wouldn't do abdominal, you wouldn't do GI or GI assessment, you wouldn't do endocrine assessment, you probably would not do a pelvic assessment on these kind of patients. So the patients that you would do one on are patients with significant mechanism of injuries, like if they've had some type of trauma, and you're getting all the way down to your full head-to-toe assessment there, making sure that you check everything. Make sure you look for decap BTLS on every part of the body. Then also on your unresponsive patients, everybody who's unresponsive is going to get a full head-to-toe assessment. So the correct answer here would be no. You don't do a full-blown secondary assessment on every patient you come in contact with. If I fall down and trip and twist my ankle, I'm completely alert and oriented. Is there a reason for you to check my heart, respiratory, GI, pelvic, every area that you possibly can think of? A full head to assessment? Why?
Why did they trip and fall?
Because I'm clumsy and I have flip-flops on and I've done trip like 3 times today.
Could have had a drop in blood pressure and caused you to vagal that. I mean, you know, there's a lot that could be going on here.
But you would do vital signs, so you would see if the blood pressure is low and then you would reassess even more, right?
My monitor might be right.
Lord have mercy. That's why you don't use a monitor, that's why you do manual blood pressure. Alright, so our correct answer here is no. Everybody good with that? A lot of you picked yes, so we're good with no, right? Alright, factors to consider when you're doing a secondary assessment. Where is your patient? Can you do a full head-to assessment on somebody trapped in a car?
If you're a midget.
I mean, if you're really good, you might be able to, but no, most of the time you're not going to be able to do a full-blown head-to assessment on somebody if they're in a vehicle. Positioning the patient, ever have the patient's position. If they're having asthma attack and they're in that tripod position, are you going to lay them supine so that you can assess their abdominal muscles, listen to their lungs, or listen to their abdominal sounds, check their extremities? Are you going to lay them down flat and do that? No, you can cause more harm than good, right? So however position they're in. Also the patient's point of view and maintain your professionalism are key components of the secondary assessment. Assessment techniques, everybody know what inspection is? You're looking, listening, and feeling, right? You got inspection, you're looking at the patient, you're feeling them, you're touching to obtain information. Everybody know what percussion is? Do we need to go over that? What is percussion? Who can tell me what that is? Something that a physician does. Do we ever do it as medics?
Nope.
We don't even do it as nurses. In my almost 9 years of being a nurse, I think I might have percussed one patient, and that's just because the doctor asked me to, and he didn't tell me how to do it because I honestly hadn't remembered how to do it. Physicians are the ones that usually percuss. You're not going to have time to do that out in the field because you got a loud ambulance. You're going to be able to hear that tympanic sound when you're percussing over their abdomen or their lungs. No, you're not going to be able to hear that at all. You can look at skill drill 13-2. I'm never going to ask you to percuss anybody, and I highly doubt any of your preceptors in the field are going to ask you to percuss anybody. But you do need to know what it is. So please review your skill drill 13-2, showing you how to do it. Auscultation. Requires listening with a stethoscope. We always look, listen, and then feel. All right, especially someone who's having abdominal pain. You don't sit there and feel in their abdomen and then decide to listen to it, because they might not have had any bowel sounds. And then if you're sitting there pressing on their abdomen, you can make bowel sounds. So you always look, listen, and then feel. Never touch your patient until you've assessed them, looked at them, then listen to them, and then you touch them. Auscultation does require a lot of practice. You can't just pick up a stethoscope and go listen and hear a heart murmur, especially if it's a grade 1. Heart murmurs are graded from what, 1 to 6, I think? Is that right?
Sure.
Sure? Grade from 1 to 6. Have a really hard time hearing those, unless you're really, really, really good. Checking a pulse. How do you check a pulse? With your fingers. Where? Where can you check pulses at? Start at the top of the head. Where can I go from here? Parotid. Where from there?
Brachial.
Brachial. Where from there? Radial.
Femoral.
Femoral.
Pedal.
Popliteal, which is behind the knee.
That doesn't work.
Pedal?
Does sometimes.
Pedal.
Pedal pulse. Pedal pulse?
No, I mean, it's not going.
Oh, okay. I was about to say, it's not a good place to get pedal pulse. Where do you check for a pedal pulse at? Top of the foot. Okay.
Question.
Where do you, yes.
Would you think it would be a smart idea for ambulances to carry Dopplers?
I really think it would be, especially if you've got someone who's got poor circulation or someone who's a diabetic. They're complaining of numbness and tingling in their left leg, and their left leg is cold and blue. You need to be able to see if you have a femoral pulse or a distal pedal pulse. And if you can't see one of those, then that's a life-threatening injury, right? Because they're about to lose that leg, lose that limb. That's considered life-threatening.
And for EMTs like paramedic who's terrible at finding pedal pulses too.
Right. I mean, that'd be a really good thing to have. It's, yeah. I'd go for that. All right. Where do you assess a pulse for an unresponsive patient? Think about this. They are unresponsive. Where is the best place out of all of these that are listed here? Where is the best place to check for a pulse in an unresponsive patient? 2 more left to go. 1 more. Thank you, guys. Man. Y'all are rocking and rolling today. Carotid is the best place to check for a pulse. And where do you find that at? In the neck, right? Usually 2 finger breaths over from the trachea. You checking both at the same time? Why?
No.
You might kill your patient. I mean, you're going to cut off blood flow to their brain, they're going to pass out on you, right? A nice little chokehold you got going on? All right. Good job. It is the carotid pulse. Always an unresponsive patient. Now, what if they're unresponsive and less than a year old? Brachial. Can you check a carotid pulse in a less than 1 year old? You're going to find it. You're going to have a really hard time. Brachial is the best place to check a pulse in a child under the age of 1 who's considered an infant. All right, this is all the places you can check for a pulse. This has carotid, femoral, brachial, radial. Pedal pulses, you can actually check on the side of the foot or the top of the foot. They don't have popliteal. Where's popliteal pulse? Behind the knee. Does sometimes, but not all the time. Depends on how big the patient is. All right, respirations. How do you assess respirations?
Count 15, chest rise and fall.
Look at their chest rise and fall, count for 15 seconds and multiply by 4, right? If they're under the age of 1, how long do you count? A full minute. Pediatric patients under the age of 1, you always count for a full minute because they have very irregular respirations. Most patients over the age of 1 have regular respiration, so you can count for 15 seconds. Now, if you notice in that 15 seconds that your patient's respiratory rate is irregular, you want to count for a full minute. Same thing when you do a pulse check. If their pulse is irregular, you count for a full minute. All right, you're assessing what their chest looks like, watching their breathing. Is it shallow? Are they having deep breathing? What's it look like? How do they look? Are they in the tripod position? Are they laying down supine? Do they have any retractions? How do you check blood pressure? With a cuff. You don't put it on a monitor, right? Hit start.
Yes, sure. NIP.
Okay.
And if it's out of range, you check blood pressure with the blue.
Technically, the best way for you to check a pulse is do it manually. So how do you check a manual pulse?
Blood pressure?
I mean a manual blood pressure, thank you.
With a stethoscope and a sphygomanometer.
That's checking for a systolic, which is usually over, whatever it is, over palp, right?
Yes.
That's not getting a full systolic and diastolic. So how do you check a systolic and diastolic with a manual blood pressure cuff?
Oh, I thought
You feel where,
And then when you hear it, that's where your systolic is. When you don't hear it, more for that.
right, you feel for a good pulse, or the artery that's in the bend of the arm, that brachial artery. That's where your little line on your blood pressure cuff goes, right up about 1 inch above that. Listen with your stethoscope, pump it up, usually pump it up to about 200. When the beeping or the beating of the heart starts, you listen to it. That's your systolic, and when it stops, that's your diastolic, just like what Anthony said. How do you check temperature?
You don't.
Well, not many people have it on the truck, but they're trying to get thermometers on the truck. What are the different ways you can check a temperature? Hunter? Feel? Okay.
Don't check it on me.
Accurate way to check a pulse if you have a thermometer on the truck.
Oral or rectal?
Oral or rectal. They also have these new things that you use in Children's Expo. You remember using those? It's the ones that just kind of wave a wand over the front of their forehead. Works really well. Rectal. They also have ear thermometers that work really good. Unless your child hates anything in their ear. What's this? A very outdated pulse ox too, right? I wonder sometimes where they get some of these pictures from. It's a very outdated pulse ox.
Oh, wow.
What does pulse ox check?
The amount of whatever's attached to your hemoglobin.
Hemoglobin. To monitor the amount of hemoglobin saturation, because your red blood cells carry what?
Oxygen.
That's why they have that nice little dip in it, right? Carry oxygen bubbles throughout your blood. If your oxygen level's low, then it's going to read below what? What's considered low? Below 95. All right, equipment used in a secondary assessment. This is all the equipment that you should need in your secondary assessment. We talked about the stethoscope, blood pressure cuff. What's capnography?
CO2 monitoring.
CO2 monitor. What's the normal range for capnography?
35.
35 to 45 what? Millimeters of mercury. All right, what's glucometry?
Checking blood sugar.
D-stick, AccuCheck machine. Ophthalmoscope? You don't have them.
Is that the
That's the eye one. Otoscope? Ear. But you can look up the nose with the otoscope. Most definitely you can. Not many ambulance services carry that. Why you have to cover it, honestly, I don't know. It's just part of the national standards. One of those things you got to cover. All right, a reliable light source, whether it be a flashlight, pin light, lights in the back of the ambulance, gloves, you need a sheet or blanket. Why would you need a sheet or blanket?
to protect your patient.
To protect your patient, especially their modesty and privacy. Okay? I'm not going to sit here and go through all of these because we all know what a stethoscope looks like, right? We know what a blood pressure cuff looks like?
I've always wondered, how do you do it?
How do you, we already covered that, not paying attention. There is an example of the different places you can take a blood pressure. You can take it using radial pulse, brachial pulse, popliteal artery, or the fetal pulse. Why would you need to use this? Or this? Why would you need to use either one of those?
If you have trauma or no patient with no arm.
Patient with no arms or trauma to both extremities,
Or if they've
or
had a
someone
double
who's had a
mastectomy.
double mastectomy, or someone who has shunts in both arms. Okay?
Oh, shunt.
Shunts. Why would they have a shunt? What's a shunt for?
Dialysis.
Dialysis. You start blowing a blood pressure cuff on that, what you gonna do to it?
Boom.
You're gonna pop it. They're gonna bleed out. You're gonna kill them. Don't do any of that stuff, okay? This is an ophthalmoscope. Allows you to look into their eyes, see if they have any problems with their eyes. However, you guys are not medical students. You're not doctors. You don't need to know what the eyes look like. Otoscope. There's really no reason for you to look in people's ears. Unless they got something crawling in there and you just want to see for yourself. I had a guy come in my ambulance one night. It was about 2 o'clock in the morning. He came in my ambulance because he had a roach in his ear. When you put the otoscope in and got to look, you could see the roach kind of moving around. It had done wiggle down in there in the middle ear, and you could see it just wiggling like that. Kind of pulled it out with some alligator forceps. I think just crunched and pulled out piece by piece. It's the nastiest thing I've ever seen. I don't know how that man didn't just dig his ears out. And that night, for some reason, we had 2. We had another guy walk in with a roach in his ear. It's freaky. All right, doing your physical exam. Do you remember us talking about in the patient assessment triangle or the pediatric assessment triangle? What components were in that? Appearance, work of breathing, and circulation. All right, we can tell that right across the room. So the first thing we're going to do is look for significant signs of stress. If I use my pediatric assessment triangle, I should be able to tell if my pediatric patient's in distress, right? I should be able to know if my adult patient's in distress. I should be able to tell if they're sick or not sick, right? Other aspects, you want to look at their dress and hygiene. Do they look like they are middle class, lower class? Are they homeless? Are they able to take care of themselves? Are they bathing like they're supposed to? Do they have an odor? What their overall size is? Are they emaciated or obese? What's their posture look like? Do they have any nasty odors? What is their overall state of health? You should be able to tell if they look healthy or not healthy. Terms to describe the degree of distress. Are they mild, moderate, acute, or severe? Y'all already know that. Are they chronically ill, frail, febrile, robust, or vigorous? What do I mean by vigorous? What is vigorous? What does that mean? Active, fast-moving, athletic build, that sort of thing. All right, you want to do a full body scan. Look from the top of their head to the bottom of their feet. Patients who should receive this sustained a significant mechanism of injury. So you would want to do your rapid trauma assessment or a rapid head-to-toe assessment for an unresponsive medical patient or anybody that's in critical condition. They're going to get a full head-to-toe assessment, correct? Focus assessment are on patients who have a focused medical injury that's non-significant or someone who has a localized trauma, like they tripped over these cords in the floor and twisted their ankle. Like me, for those of you who were here whenever I decided to fall down one step in the nursing room. None of y'all were here for that, I don't think, were you? No, none of you guys were here, thank goodness. Bless your hearts. I think Steve had to bring the entire advanced EMT class down there. I literally fell. If you've ever been down in 104, the tiered classroom down there, the steps are about that high. They're not high at all. And I had just finished lecturing trauma for the nursing students because I was working on my grad degree. And I went to step down off the last step to go back to the podium. Whenever I did, my shoe caught the end of the step, the top part of the step. Twisted my ankle, thought I broke it because it popped, and then landed right on my hip. I thought I broke my hip and my ankle. It was a mess. And Bill Dye, if any of y'all know Bill Dye, came in front of 70 nursing students and 20 of my students and asked for somebody's bandage shears because he was going to cut all of my clothes off. Because the first thing you do in a trauma is
Expose the...
expose. After you check their ABCs, you're going to try to expose them to look for any other injuries. That was probably one of the worst lowlights of my day. It was miserable. And then Dawn McLeod forgot the drug box key, so they couldn't give me any pain medicine. And then he called a report to the ER and said, this patient's well known to you, so he made me sound like a drug addict.
Was it Dawn really forgot the keys?
Yeah, she really forgot the
I'm gonna
key in the
bug her
marketing
about that
box.
because I see her at shit today.
Yeah. Because Bill's like, I'm going to give you something for pain, but Dawn left the keys, and I'm like, really? Really? And I roll in, and if you know Nick Tolshe in the ER, he was my nurse, threatened to cath me and everything else, and it was just miserable. That's the only bad thing. If something ever happens to you in this area, you know everybody that responds, everybody that works there. It was miserable.
That's why when I wrecked my car, I made sure I didn't call anybody.
Yeah. So your focus assessments are due on those patients who have non-significant injuries or a localized medical condition. Tells you right here on table 4, chest pain, you want to evaluate their skin, pulse, and blood pressure. Assess for trauma to the chest. You have to expose the chest area. Just like if they're having abdominal pain, you need to expose that abdominal area. Mental status for any patient with a head problem. Assess and palpate for signs of trauma. Assess the person to see if they're alert and oriented times 4. So you're checking for person, place, time, and event. Used to be A&O times 3. Now it's A&O times 4. They've added that event to it, so they know what's going on. You use the Glasgow Coma Scale. Y'all familiar with the Glasgow Coma Scale? You learned that in basic, didn't you? I thought so. For a minute? You learned it for a minute?
Yeah.
Alright, assesses points value for eye opening, their verbal response, and their motor response. So are they alert? Are their eyes completely open to you? Are they able to speak to you? Are they able to move everything as you command? Alright, let's try one. 49-year-old male who opens his eyes in response to pain, has slurred speech and is disoriented in his speech, and withdrawals to pain. What is his Glasgow Coma Scale? I would suggest that you know that, by the way. That will be on your test.
And we use our apps.
Huh? No.
Can I call the stroke system and have them do it
No.
for me?
This is something that you really need to try to learn how to do at the paramedic level. It's a very important thing for you to learn how to do.
But it calculates it for me in my charting.
Yeah, I know. Were you in chapter 13? You're on the right chapter. You just gone back to use gone to them. No.
636 is what we had.
Okay, you're right. Alright, so he's 49 years old. He's opening his eyes in response to pain. He's disoriented and slurred in his speech. And he is withdrawals to pain with his extremities. What's his Glasgow Coma Scale? There's 4 of you left to go. One more. There we go. All over the board. It's 10. Woo-hoo-hoo-hoo, 10. Alright, so what's he get for eye opening?
Open the pain.
Gets 2, opening to pain. What's he get for his verbal response?
Incomprehensible.
He should be a 4. He's disoriented, incomprehensive speech. Alright, withdrawals to pain, motor skills. Oh wait, that was 4, yeah. And then 4 more makes 10. I can't count my hands today. What we say if they're less than 8? Less than 8 intubate, because they're not able to control their airway very well. What's the GCS of this table?
0.
3.
Oh yeah, you always get a 3.
Always get a 3.
So is that confused speech or incomprehensible speech if we're slow?
Confused, disoriented. A little tricky, huh? Alright, checking their mental status. We've already talked about we're going to assess if they're alert and oriented times 4. Checking their AFPU, getting a Glasgow Coma Scale. Also, checking their mental status, looking at their general appearance. If they're a 49-year-old male and they're prancing around in a tutu, they might not be all the way there. Brandon does on weekends. It could be normal for some folks, but speech and language patterns, are they talking to themselves? Are they able to communicate normally? What is their mood like? Are they happy, sad, irritated, aggravated? Thoughts and perceptions? What is their insight and judgment? If they leaped off the building, do they have good judgment? No. Cognitive function, they're able to retain information. Like your patients who you think might be having a stroke, you tell them 3 objects and then you have to ask them again 5 minutes later. Like you tell them spoon, yellow, dog. Repeat those 3 things back to me in 5 minutes. Spoon, yellow, dog. Okay, I got that? Spoon, yellow, dog. Alright, next we're going to look at their skin. What does your skin do? It protects you, right? It helps regulate your temperature. It protects you from environmental problems. Now the three layers of skin, the epidermis, the dermis, and the subcutaneous tissue. Where's the first degree burn at? Second degree? Third degree? All three into the muscle, right? All right, you're looking at their skin, you're going to examine for color. Also look for moisture and temperature, texture, turgor. How do you check turgor? Pink on the skin. Real emaciated people or even your pediatric patients, you want to pinch skin over the clavicle. Best place to do it. Other patients, you can check on the back of their hand. All right, look for any significant lesions. You're also looking for bruising anywhere, hematomas. Signs of distress and poor perfusion would be pallor. What's pallor? Pale, white. What's cyanosis? Diaphoresis? Sweating. They got lots of moisture, right? Like Stan over in the sim lab, you know, when he sweats, he actually shoots water out of his little probes on his face. And vasodilation causes a lot of flushing. All right, what is this picture? Is it considered ecchymosis, poor turgor, or modeling? What is this picture? Kimberly's not here. That's who I'm missing. Ashley's in Kimberly's feet. I knew I was missing somebody else.
All that trickery.
All right, one more. Here we go. All right, what's ecchymosis?
Around the belly button.
Bruising, like you would see maybe around the belly button or in the left upper quadrant for someone who's got a spleen injury. What's poor turgor? How would you assess that? Patient on the skin, on the clavicle. What's modeling? That. Right there. That's modeling. What is modeling? What's it caused from? Poor perfusion, which can be caused from heart disease, diabetes, smoking. Also can be caused because they're cold. A lot of pediatric patients model most of the time. They're cold. They're usually cold. Also, modeling can be a sign of hypovolemic shock. And then the pediatric patient whose modeling does not go away when they are warmed means they're in shock. Adult patients, they usually model because either they're cold, once you warm them up, if it doesn't go away, they're in hypovolemic shock. You good with that? Modeling is a sign of shock, but also a sign of cold, poor perfusion. All right, so if we're vasodilating, our skin's getting flushed. But if we're vasoconstricting, our skin's getting what? Pale. Good job, pale. All right, talked about modeling, severe hypoperfusion and shock. All right, talked about ecchymosis, all that. We've already talked about all that. Next, we're going to examine the hair. What are we looking at with their hair? I mean, is it disheveled? Is it everywhere? Do they have hair? Do they have patches of hair missing? What's it look like? Is it soft and shiny, or is it dull and frizzy? Like they have poor nutrition?
No, it doesn't matter.
I don't know what you mean. All right, next you're looking at their nails. What are you looking for in their nails? What do their nails look like? Checking capillary refill, which should be pink in less than 3 seconds. All right. You're also looking at their nails. Do they look clean and dry? Are they a chronic nail biter? Are they bit all the way down the cuticle? Are they dirty? Like they don't take proper care of themselves? Your homeless patients are going to have very dirty fingernails. Also look for clubbing. What's clubbing a sign of?
Their fingernails. COPD.
COPD patients have clubbing. Usually it's where their nails kind of club over. Stiff? CF, yes, which is cystic fibrosis. Think about that for a second. Usually if you've got clubbing of the fingernails, then they have some type of breathing abnormality, some type of respiratory illness. Or they could just have clubbing in their fingernails. My sister-in-law's fingernails club, but she doesn't have any respiratory issues. She probably will. She was a smoker for a long time. Then got a blood clot. She was also on birth control. Got a blood clot in her arm, of all places. Isn't that weird?
Get off birth control now.
Well, she quit smoking and quit taking birth control. That's the reason I have a nephew. Yeah, her and her husband that she had known for like 2 months got married.
accident.
Well, he was a beautiful accident. He is the cutest little thing. He's absolutely adorable. He was a nice little, he was her present before he went off to Afghanistan, so then he was gone for a while. All right, you're also looking at the shape, the texture. Do they have frail, brittle nails? That's a sign of malnutrition, right? Checking their head. There's all parts of the head. Checking the frontal lobe, the occipital lobe, the temporal lobes, every part of their head. Y'all already know all that. You can check for cerebral spinal fluid leakage from the ears to the nose. How? Halo test, but you can also check it with glucose meter. I think Sam told us it was, what, 40 to 60? 40 to 60? Does have blood in it, by the way, just in case you guys didn't know. Does have just a tiny little bit of blood in it. Inspect and feel the entire cranium. Check for deformity, asymmetry. If there are any warm, wet areas, which might indicate what? What's warm and wet? Blood. Also cerebral spinal fluid. Check for tenderness, shape, and contour. Also look for any scars or shunts. You're not going to be able to feel a shunt. It's in the brain, but you should be able to feel scarring. They have a huge scar right through here. 9 times out of 10, they will have a shunt. There are some patients whose shunts do bulge out, but a lot of patients, you can't feel them. You can feel the scar. Next, evaluate the face. You're looking for color, moisture, expression, symmetry, and contour. You check DCAT BTLS on everything that you touch. You know what that is? Or we need to go through that. I think you're good on that? Okay. Next, looking at the eyes, checking pupil responses. Make sure that their eyes are in their head, of all things. They're not bleeding, sliced open, having drainage, just gross. And you picture what an eye looks like. A cartoon character eye. Note if there's any periorbital ecchymosis, which is known as raccoon eyes, also considered a, what kind of sign? Battle sign, okay? Battle sign. Assess visual acuity if you have time. I mean, I don't know when you're going to have them standing 20 foot from a Snellen chart, but, you know, if you got time, do a visual acuity. Put this Snellen chart on the side of the ambulance, have them stand right in the middle of the road. Okay? Please don't do that. I was just
Somebody will do it.
just go ahead and say that. Okay, well, I can assess that. Especially with Kane, bless his heart. All right, what is this a sign of? Kane's actually been really quiet. Aren't y'all a little scared? I am.
Yeah, well, first thing you do is get on to me when you walk in, so I figured it might as well be quick.
All right, what is this for one thing?
Raccoon eyes.
Battle sign. The raccoon
Behind the
eyes.
ears.
Battle signs considered periorbital ecchymosis.
Oh, battle signs are
And
behind
you
the
also
ears.
have bruising behind the ears. But raccoon eyes is known as battle sign. So what is this indicative of? There's only 16 of y'all answered. Everybody answer. Liver failure? Is that what you said? It's considered a sign of a basilar skull fracture. What is that? Which is where?
The bottom part of the skull.
Bottom part of the skull, which can be seen with head trauma patients.
With X-rays.
Sometimes they'll have head trauma patients. Sometimes they can have all over head trauma and they'll have a Lafort fracture. What's a Lafort fracture?
The actual face.
There are different levels, but the most significant level of a Lafort fracture is all of this right here that you can literally grab that and pull it out.
So it'll make it easier to inculate.
Yeah.
No.
No. But you can. I've only seen one Lafort fracture in my life, and this girl got a stop sign to the face when she wrecked her car.
Yeah.
Had a very severe Lafort
How
fracture.
did the, she fly
Suction.
out?
Yeah.
No, did
They
she
had to bring her
get
to the hospital,
No,
and then they
did-
flew her out.
Did she fly out of the car? Like, how did the stop sign hit her? in the
It
face?
came in the windshield.
Like
Yes.
sideways?
It says that the battle sign is behind the ears.
It does? Okay, I apologize. Thank you for letting me know that.
Well, I didn't want to get.
I thought it was raccoon eyes.
Well, this is raccoon and battle signs is just behind the
Somebody
ears.
said that before, so,
Say that again?
but the book did teach us last semester.
Yeah, that'd be nice.
Just behind the ears? But it's considered both, right?
Yeah.
Well, raccoon eyes
later
is-
on, somebody-
Like when it talks about eyes, it says raccoon eyes, it talks about the ears.
It says battle sign? Okay. Well, according to your book, battle sign is behind the ears then. We'll just call the eyes raccoon eyes. They do represent the exact same thing,
It's a
yes.
late sign.
It is a very late sign. Battle sign behind the ears is a late sign. Periorbital ecchymosis or raccoon eyes is an early sign. All right, next you're assessing pupils. Checking for reactivity. Are they constricted, dilated? Are they active, non-active? Or reactive or non-reactive, excuse me. Sluggish. Next, you're looking at the ears, what their ears look like. Do they have any drainage coming from their ears? Here's a nice little picture of the ear. It's hot in here. Y'all hot? Can we open that? Should we open that window, please? I'll open this one.
I went to the very, right here when I get to
I'm at the road. You can look at skill drill 13-7 and it talks about examining the ears with an otoscope. You're not going to be doing it on the truck, but you're welcome to look at it. Also, you can check for tenderness at the mastoid, which is this little area right here in the ear. Your pediatric patients, they have an ear infection. You touch this little area, they're going to climb out of their seat. It's the number one sign showing that they've got an ear infection. Pediatric patients can't talk to you, especially if they're under the age of 1. They can't tell you their ear hurts. They can be clawing at their ear or have a low-grade temp, and you can touch this little area right here, and they'll claw themselves to death or try to jump out of the seat or start screaming bloody murder. Next, look at their nose. Check for any deformity. Make sure it's symmetrical. Any wounds, foreign bodies stuck up their nose. Who's going to stick foreign bodies up their nose? Pediatric patients. Logan used to stick sausage up his nose. He loved kielbasa sausage when he was a baby. He still does now. But we'd have to cut it up really small after we'd fry it for breakfast. I mean, teeny tiny little pieces. And Josh walked in one day after he had been in the kitchen cleaning up, walked back in the living room, where Logan was in his little high chair thing, and he had shoved almost every piece of sausage that he had up his nose. That was interesting. I got a phone call at work. I was in the ER, and he's like, our son just shoved all of his sausage up his nose. He had to sit there with tweezers and dig it out. It was.
How did that go?
I told him, I thought, that's what you get for leaving him alone with food. I mean, he went for like a year and a half. You don't leave kids alone with food. But I guess what happens when daddy stays at home with daddy. Next, you're going to evaluate the throat. What are you looking at for the throat? Opening their mouth, looking at their tonsils, looking at their uvula, make sure it's midline and hanging, no problem. Of course, if they had a tonsillectomy, you're not going to see their tonsils, are you? Make sure there's no obstruction. Checking for any vomitus. Be prepared to suction. Long today. Look for any cyanosis around the lips, which is going to show that they've got poor oxygenation. Check the tongue for color, moisture, size. They're on ACE inhibitors. They can have what? Angioedema, which is swelling of the lips and the tongue, which can cause airway obstruction, right? Check their maxilla and mandible, all their little bones in their face. Check their oropharynx. See if you have any pustules anywhere. Check for edema and redness in the back of the throat. Neck, you want to check for symmetry. Look for any masses. Have JVD. Is there trachea midline? You all know this, right? Cervical spine. Always consider mechanism of injury. If I trip over this cord and hurt my ankle, do I need C-spine?
Did you hit your head?
Did you hit your head?
I did not hit my head. No, I just tripped over this and kind of fell down like that. Did not hit my head. Do I need C-spine?
You would consider it.
You would consider, but do I need it?
I don't know.
No. My neck does not hurt. I'm able to move it, no problem.
Before you
No
had
hurt.
any neck surgery?
Nope. 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 I just hurt my ankle. You quit talking about my neck. My neck is fine. My ankle hurts, okay?
Well, we left more people.
No. I don't know, I might, because I'll probably be extremely embarrassed. I'm telling you, when I fell down the stairs downstairs with 70 plus students, I was extremely embarrassed. The funny thing is, I had just got finished talking about trauma,
Hey, demonstrate.
of all things.
If you're a person that calls CMS because you took over the 54, the more time we package you, the less you're going to call.
That's probably true. But however, according to national standards, am I going to need a C-spine?
Yeah, that's
It's
wrong.
to the discretion of the
You
man.
fell, we didn't see you fall. That's
Yes, you
wrong.
did. You're all in here.
We're not responding to the call.
Yeah.
had a stroke and shit.
Lord have mercy. All right. EMS arrives on the scene, a 19-year-old male who was found unresponsive next to his vehicle by some friends. Patient was found on the ground supine. Does this patient require C-spine immobilization? Based on mechanism of injury. Strictly based on mechanism of injury and what your patient looks like, does he need C-spine immobilization?
There's not necessarily a mechanism.
We don't know the mechanism.
He's laying supine.
Exactly. Think about it. 2 more left to answer. 1 more. Why does he need CT spinal mobilization?
You don't know.
You don't know what's wrong with him. He was found unresponsive on the ground. Did he fall there? Did he lay down and pass out? What kind of injury does he have? And he's completely unresponsive. So he would need CT spinal mobilization. That
You
is
check
correct.
for a pulse first.
Well, of course. You would check your ABCs first, of course. Huh? Hopefully all of you. While I'm in here and according to your national standards, what are you going to do? Exactly. And then check his ABCs, right? And then package him. Find out what's wrong with him. Get him to the hospital. How long are you going to be on scene? Less than 10 minutes. Get out of there, right? Is he considered stable or unstable? Stable or unstable? He's unstable. He's completely unresponsive. You have no idea what happened to him. He's going to be considered an unstable patient. All right. Next, you want to inspect and palpate the cervical spine. Let them have passive movement and then active movement. Feeling, making sure you're checking for any decap BTLS. Add another L there. Next, you're going to move down to the chest area. You're going to contain, which contains the lungs, heart, and the great vessels. You're going to examine the chest wall, listen to lung sounds, and then listen to heart sounds. Where do you listen to lung sounds at? Left to right, left to right, left to right. At least here, then down here at the base, then along the back, straight down. So you listen over what, 9 different places? No, 6 different places, excuse me. You can. How many people just listen here and here? Almost everybody. But according to your book and national standards, you really need to listen to those, at least those 6 different places. Where do you listen for heart sounds? Where's your heart?
It depends if you want to listen to
What part of the heart you want to listen to? Where's the best place to listen to heart sounds? Starts with an E. What's it called? Right at the sternum, which is known as Erb's Point, right here in this area. That's about fourth intercostal space, right on the left side of the sternum. Thank you. No, that's left.
I remember going to test.
What's the heart rate?
Then you have to listen to it the opposite way. Not many people are born that way. There are a few.
There's one in
There are a
our
few.
here that is a frequent flyer. Little girl.
It's crazy, isn't it?
I take it in her children's.
Mm.
It's the sweetest little boy.
See, I don't know. Can they not throw up?
Well, that's what kind of she can't throw up. Why? My heart's good.
What does that have to do
Can't
with?
throw up? No, I can't throw up.
I don't understand what that has to do with anything.
But I was going to ask.
Yeah, I honestly do not know that. All right, you're looking at their chest wall, checking for symmetry. What does their respiratory effort look like? Are they using any accessory muscles? Auscultate breath sounds. Listen for any abnormal breath sounds. The sounds sound dry or moist. Are they continuous or intermittent? Are they fine or coarse? Are they diminished or absent on one side versus the other? Assess their respiratory rate, depth, quality. Also assess for jugular vein distension. What is JVD a sign of? Pericardial tamponade. You can have a tension pneumothorax, or it can just be a sign of heart failure or carotid artery disease. All right, Nick said he's already gone over cardiovascular assessment with you guys, so we're just going to kind of slide through these. He told me yesterday that he went over this with you after I made this. You already know what the systems are: arteries, arterioles, capillaries, venules, veins. We need to go over those. Cardiac cycles involves cardiac relaxation, filling, and contraction. Consists of 4 chambers. You know the 4 chambers, right? I hope by now in cardiology you guys know that. You know how the blood flows through the heart? Okay. Heart sounds. Have your lub dub. I don't really need to go through those. What's a Korkoff sound? It's a heart sound.
Blood pressure center.
It's related to the blood pressure. You have the first thumping of the systolic blood pressure, and then the fifth disappears and the diastolic blood pressure drops off. I don't care that you know that, in all honesty. What's a bruit?
It's when you have like an AD draft, you hear the thrill, feel the bruise.
You feel the thrill, hear the bruit. What does a bruit sound like? When you have someone who's got a graft, a dialysis shunt, you will hear a bruit in that. What it is just blood going through a tiny artery. That's what it sounds like. It just goes shh, 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 shh. Huh? Yes. Also can hear murmurs if you're really good at listening to heart murmurs. I don't know many people that are other than cardiac physicians or cardiac nurses. I already talked about arterial and venous pulse. I already talked about JVD. I need to go through that. When would you palpate and auscultate the carotid arteries? Maybe if you're thinking they might have a blockage in one of their carotid arteries, what would you hear? We just talked about it. Blood going through a narrow artery. A bruit. You would hear a bruit if you listen over their carotid arteries. What part of your stethoscope are you going to listen over with? The bell, the tiny little piece. These are all the different places you can listen throughout the different valves of the heart. We're going to have that for your reference. I'm not going to ask you that. I'm not going to ask you which intercostal space you're going to listen to the mitral valve at. Heart problems. Anytime a patient has any heart problems, you're going to check their pulse, their skin, their breath sounds, baseline vitals. Look at their extremities. If they get good perfusion or poor perfusion everywhere. The definition of normal and abnormal findings is different in a neonate and an infant, of course. Their respiratory sounds and heart sounds might sound extremely irregular, but that's normal in a neonate or an infant. So what you might think is abnormal in an infant or a neonate that's just been born is considered normal. All right, next to the abdomen. So we're moving from head to toe. Abdomen's divided into 4 quadrants. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Contains all your organs, whether they be peritoneal or retroperitoneal, or intraperitoneal or retroperitoneal, also known as extraperitoneal. What are your extraperitoneal organs? Outside the perineum, which is kidneys. Everything else is pretty much inside the sac. I'll talk about that. Different types of pain, your visceral pain, inflammation, and referred pain. We talked about pain the other day. Visceral type pain that has a sudden onset is known as what kind of pain? Acute. Persistent pain that's difficult to treat is known as pain localized in an area different from the actual pain is referred. If you're having a chest pain, having an MI, where are you going to have pain at? Where's the referred pain going to be? Arm. Usually down your left arm, also under your left shoulder, maybe under your jaw. What if you get a spleen injury or a gallbladder problem? Your right shoulder scapular area. All right, what if it's your appendix? Where's that pain located? Right lower quadrant. You can also have pain around your belly button. Early sign of appendicitis is referred pain around the belly button. Then it moves down to that right lower quadrant. You know what the number 1 cause of appendicitis is? Fecal impaction, constipation. Did not know that. Isn't that weird? Constipation is the number 1 cause. My grandma, I used to bite my fingernails all the time. My grandmother used to tell me that if you keep biting your fingernails, you're going to have your appendix removed. Well, my very first year here, we had registry, and I had been hurting since the night before. We did Matt Knight's retirement party. Y'all know Matt? Y'all, half of you probably don't know who Matt Knight is. Some of you do. They've been here for a while. We had his retirement party, and we were on our way home, and my stomach started hurting. I was like, oh my gosh, what the world is that? And then I got home, came in the next day, and we had my very first time with registry. Very first time being here. It was for our night class, so we were here till about 10, 11 o'clock that night. And I'd been hurting all night long. Did not have a clue what was wrong. I had gone to the doctor early that morning, and they thought, oh, you might have a kidney stone. I'm like, really? Hurting right here, a kidney stone? Okay, whatever. I thought, as a nurse, maybe it's an ovary. Maybe like an ovarian cyst or something. Went the next morning for my CT without contrast. If any of you know anything about CTs, when you have one without contrast, you really can't see squat. You have a really hard time looking at the actual organs. I don't think I was gone from the hospital 5 minutes. They called back and said my appendix was extremely large, ready to rupture, and I had to come out of the hospital right away. Went into emergency surgery, and The rest is history. It's probably one of the most uncomfortable surgeries I've ever had in my life. If you've ever had abdominal surgery, it is by far, to me, the worst. Yours wasn't that bad? Mine was horrible. Oh, you were a kid. Kids are real resilient. But anyway, the thing was, and I got to thinking about it, my stomach had been upset, and I wasn't able to go to the bathroom like, you normally are able to. And then I started researching why my appendix ruptured. I was like, really? Was it from biting my nails all those years? Was my grandmother really right? And I started researching it and then realized that the number one cause is constipation or fecal impaction, which I thought was really odd.
I guess that was why they related to the after childbirth. But that's when I had mine. I had
Yeah.
my son.
You should have had
You
some.
have a kid.
When you have a kid,
When you have a kid after.
yeah, you don't poop for a while if you have a kid, which, I mean, if you're ripped from one end to the other and you've had stitches and stuff, the last thing you want to do is poop. Because you got to think you're sitting on a toilet, you're bearing down, all that stuff's pressed on your stitches, and
That's like when I had
yeah, you don't want to bear down at all. It's uncomfortable. No. All right, so when it comes to the abdomen or any part of the body, we look, listen, and then feel, right? If your patient's complaining of right lower quadrant pain, is that the first place we assess or the last? Last place you assess. Also can do orthostatic vital signs. What does that monitor? What does that look for? Called a tilt test. Checking their blood pressure and heart rate when they're lying down, sitting up, and then standing up. A drop in the blood pressure and an increase in the heart rate is a positive tilt test. If they're systolic or diastolic, increase by 10, and their decrease by 10. Systolic will decrease by 10. Diastolic will increase by 10, and then their pulse will also increase. This happens to a lot of patients who are recent surgery patients or in hypovolemic shock. They stand up too fast or get out of their seat too fast, they will pass out. Always examine the area of complaint last. You're looking at their stomach. What does their skin color look like? They have any stretch marks, scars, wounds, any distension, any pulsations. If you had a pulsation in the abdomen area, what is that a sign of? A AAA. What's a AAA? Abdominal aortic aneurysm. Do you palpate that? No, you leave it alone. You start palpating, and what are you going to do to it? Liable to rupture it, and how fast are they going to bleed out? Before you even get them on the stretcher, they're going to bleed out and die. All right, abdomen is considered either flat or rounded. Protuberant, which is considered bulging out. Distinguish if it's from obesity. If you've got someone who's got cirrhosis and they have ascites, what's ascites? Swelling of the belly. They're pregnant. Is that considered obese or protuberant? Protuberant, because they have increased swelling. Pregnant woman, protuberant or obese? If it's just they could be big everywhere, but mostly it's just from the bulging out of the belly. Also, what's scaffold? What's that mean? Scaffold. Scaphoid. I can't say that word. Scaphoid. Thank you. What does that mean? Think of those poor little Ethiopian children, people who are malnourished. Their stomach kind of sinks in. They're big up top, and they just kind of sink in. Not washboard abs, but like sunk in belly. Look very emaciated. And pulsatile, they have a mass that's pulsating. Auscultation. Are you going to be able to hear bowel sounds in the back of an ambulance? Probably not. How many medics do you know check bowel sounds in the back of an ambulance? Like none. Even if they're complaining of abdominal pain. You rarely ever see it, huh?
Every day on clinical opinion, make sure everything.
That's a good thing. You need to be able to do everything because what happens a lot of times is you get out of here and you go to work and you get lazy. You get lazy. How many lazy medics do you know? I'm pretty sure everybody can think of at least one. You get lazy. Last thing you want to do after you look, listen, and feel is palpate for pain. Genitalia. When's the time you're going to look at the female genitalia? Well, you're going to look at it at some point in time. If they have a straddle injury or if they are impending labor.
That's what you just get to the hospital. Get in the back.
You're going to be the one whose baby delivers in the back of the ambulance while you're trying to drive down the road. Because you're giving it a lot of gas instead of actually looking. You got to look. The only time you're really going to look at that area. They have some type of straddle injury. Like they got bucked off a horse and landed on a fence. You need to look at that area to make sure there's not any bleeding that needs to be controlled. That would be horrible. I've been bucked off a horse, but landed on the ground. Luckily, I didn't land on nothing else. All right, you want to be very discreet and limit this area. That's why you have a sheet to cover everything up. If she's 39 weeks pregnant and telling you she's having pelvic pain and feels like she's fixing to have a bowel movement, then you need to assess and make sure the baby's not coming out. Now, if she tells you she's having brown-green discharge, you're going to pull her pants down and look.
No.
You'll take your word.
You're going to take their word for it and get to the hospital, okay? What about if it's an ectopic pregnancy? Where are they going to hurt at? Where? They're going to hurt either right or lower quadrant, because you got to think that's where their fallopian tubes are, right? And an ectopic pregnancy is a pregnancy inside the fallopian tubes. They're going to hurt in this right lower area. If they have right lower quadrant pain, nausea, and vomiting, it's either appendicitis or an ectopic pregnancy if it's female. And what did Dr. Sin tell you? The choice on the test is probably an ectopic pregnancy. That's for medical tests. You're going to have to read my questions, okay? Male genitalia, when are you going to look at that? All right, when are you going to look at male genitalia?
Sweep it for that.
If they're complaining of a priapism, what's that from? What is a priapism? Erection lasting longer than how many hours? Longer than 4 hours. Patients who have sickle cell disease can have priapism. There's one that comes in the ER all the time. Spinal cord injury caused priapism. Patient who took Viagra decided to take way too many happy pills. You're going to have to examine that area. Also, if they have a straddle injury or testicular torsion. If they have a testicular torsion, where are you going to see bruising, you know? In the inguinal area. Where's your inguinal area? Do we need to point to that? Do y'all know what your inguinal area is? Let me give you a hint. You usually check for a femoral pulse in this area. Okay? All right. Now on to the not so gross topics. Musculoskeletal system. Checking their joints. If they have fractures. If they've got a fracture to their left arm, you're also going to check for PMS in any extremity that has a possible fracture. Look for open wounds, hematomas, contusions, obvious deformities. Check range of motion. Passive first. What do I mean by passive range of motion? What the patient can do. Passive, patient. Like a passive range of motion is the patient, what they can do. Active range of motion is what you have to do. And this guy, do you need to test range of motion to his arm and shoulder? No. I don't think he does either. Inspect their elbows, wrists, knees, ankles. You're looking for symmetry, pulse, passive and active range of motion. We'll go through all that. All right, next is the vascular system. You're looking for full head to toe, color, checking their lymph nodes. Where are lymph nodes at? Everywhere. In every crease that you could possibly think of, there's a lymph node. Okay? Next, under your arms, inguinal area. Check for raised or inflamed lymph nodes. How many of you are actually going to check for lymph nodes? Probably nobody. I don't see many medics doing that. I don't even see many nurses doing that. Only time I ever checked for lymph nodes if I had someone complaining of groin type pain or someone who had a sore throat. You'd always check lymph nodes to see if they're enlarged. Why would your lymph nodes be enlarged? Infection. Cat scratch fever. Some type of infection. What do your lymph nodes do? Collect nastiness, right? Help get it out of the body. And if they're inflamed, then they're collecting a bunch of nastiness that's not getting out of your body. It's a way to think of it. All right. Also check for the 5 P's when it comes to peripheral system. This is everywhere. Check for pain, pallor, paresthesia. What's that mean? Sensation, right? Are they able to feel it? Are they paralyzed? Are they able to feel any sensation at all? What's that other P word? I can't say it. They should have just said poor temperature. Okay? You're checking temperature. And pulselessness. Do they have a pulse or not? Y'all go with the 5 P's? So we're checking for pain, pallor, which is going to tell us if they've got good color, good circulation. Checking their sensation, or paresthesia, seeing if they're paralyzed anywhere, have any sensation. Checking their poor temperature, if they have good temperature or poor temperature. And checking to see if they have a pulse. spinal column, down their back. They're complaining of back pain. You can go from the base of the skull all the way down to the coccyx. I don't know when people go down all the way to the coccyx. I think you might make it to the sacrum, unless you're going to be sticking your hand down their pants and their butt crack. Inspect their back for lordosis, kyphosis, and scoliosis. What's this a sign of? Lordosis. Who is at risk for lordosis? Main population at risk for lordosis. Huh? I heard it. Pregnant females. Why? I mean, all that weight right here, you're already doing this, right? Who's at risk for kyphosis? Elderly patients. They become little humpbacks, bless their heart. Scoliosis is anybody. When do they check for scoliosis? Elementary school. Do you remember getting that exam in your elementary school? You had to bend over and touch your toes? All right. Which spine abnormality is common with elderly patients? We just talked about this. So y'all should all be able to get it right. It's a clicker question, just in case y'all were wondering. Really? Just 8 and 17% of you guys really not know that answer? Or did y'all just click something? Yeah. They're not going to say. Kyphosis is common with your elderly patients. Do y'all need a break? A potty break? We still have a long ways to go.
Oh, yeah.
All right.
I need another spring break.
I didn't even get my spring break.
I did either.
All right, y'all take 10 minutes. Gives me time to run downstairs and grab my water. Thank you. This will be going for exactly an hour. All right, we already talked about palpating over the spine. Check for range of motion. How do you check for range of motion of the spine?
You shake them real hard.
That's the cane I missed. You can't say a word all day. He was saving it up. How do you check range of motion of the spine? Passively and then actively, right. So how do you give it passively? Come to bend down,
Please move.
back and forth, side to side. How do you check it? Push them down. Actively moving the spine is not a very easy kind of thing to do. All right, next you're going to check the nervous system. How are you going to assess the nervous system? Sensation, you'll check it that way. Also checking their pupils, talking to them can assess their nervous system. What are the cranial nerves? The 12 cranial nerves. I would like for you to know them. I would like for you to know them. Just think about it. It's not going to be something hard. I'm not going to say match the number to the other thing. All right, everybody stand up.
I'll tell you what.
Move your chairs back. Everybody stand up.
You never see that?
I think I know.
The only cranial nerve.
Hey, we got one. I gave him this change.
What is it? I don't know the answer. Huh. Everybody up? Y'all can spread out, move around. You need to have some dancing room, so move around. I want to see you breaking it down.
I've got this one
Okay?
thing that I gotta go do real quick.
Shut your mouth.
Jeez, I hope you're not recording.
This way, baby.
Oh, come on.
This is the PA class of 2014 at RFU. I am Professor.
This is really cute. I really enjoyed this when I watched it. It was funny. Where's my volume?
Drop it low to you.
It's all the way up.
Calculation, and we are going to teach you the cranial dance today. First nerve we're going to learn is the olfactory nerve. It is nerve number 1, which is why you have one finger and pointing to your nose. It does the smell.
Where would that be? I don't know if the speaker's plugged in.
Alright, next up is optic.
Dang, this is a really cute video too.
Just hate it.
I really hate it too.
I get extra points if I fix it.
Anthony, don't be going up there and trying to figure.
Or constriction of your pupils and general eye movement. And we're on to cranial nerve number 4. It's the trope.
The slides up whenever it finally lets me, so I want you guys to
Just put your paws up. 'Cause you were born this way, baby.
Class of 2014 at RFU. I am Professor Calculation, and we are going to teach you the cranial nerve dance today. First nerve we're going to learn is the olfactory nerve. It is nerve number 1, which is why you have one finger and pointing to your nose. It does the smell.
Alright, next up is optic nerve number 2. Dance move for this is putting your fingers next to your eyes because it's the nerve for vision.
Alright,
This isn't gonna work either.
All right, you guys, I got 8 crates of Epicac from Mort, all on my tab. Now, whoever goes the longest without puking gets the last piece of...
Well, see, if the microphone's not plugged in, then we're not gonna be able to hear it on the recording. Okay. I'm not gonna waste any more time looking for that. I'm sorry. I was really hoping y'all would get to do this because there's a really cute little dance you were gonna be able to do it. And see how coordinated some of you are. But watch it if you've got time. It's a really good way to learn your cranial nerves.
Do you know it?
No, I just watched it the other day. I was going to do it with you. No, I'm not that good. I'm good, but I'm not that good. All right. Checking the voluntary and the involuntary nervous system. Your involuntary nervous system is the sympathetic and the parasympathetic. You can't control that, can you? Nope. Your reflexes, you can't control that either.
That's really, I don't expect some, but there's a dude I saw in the ocean that controls central nervous system. He stood in a bucket of ice that goes up to his neck for over an hour and didn't have room enough to walk out of him.
Why would you do that? Just to prove that you can? Interesting. All right, doing a neuro exam, checking their pupils, checking for AFPU. We've already talked about all this. Check the reflexes. How many of you are going to check tendon reflexes? None of you? Yeah, I don't see why you would. Something they can do in the emergency room setting. Not something you need to worry about. Mental status exam. Check for consciousness, orientation, activity, speech, their thought process, their memory. What are those 3 things I told you to remember? Any of you remember?
Yellow dog.
I did say 5 minutes. This is way longer 5 minutes because I forgot about it. Spoon, yellow, and dog. How many of you did not remember those words? Sam was the only one that didn't remember? Anthony? Did you even pay me any attention? I told you to remember 3 words.
What if you don't remember them in the correct order? Does that count for anything?
No.
What?
You do not have to remember it in a correct order. You just needed to remember those 3 words.
Okay, good. Let you say no, no credit for it.
You can ask them to remember 3 words that have no meaning to each other. My brother-in-law got a concussion during a football game one time, and he tried to go streaking across the football field and tried to dance with his girlfriend, but it was another football player, so it didn't really work out very well. It's an interesting day. That was an interesting football game. All right, Glasgow Coma scale. What's the best you can get? 15. What's the worst? 3. So all of you in here should have a 15, and that table should have a...
Randy, I will argue that because that table doesn't have eyes, so you can't have 1 point for that. You can't give 1 point for that. They can't make good. You can't give 1 point for that.
A dead body.
They can't make a noise, so you can't give 1 point for that.
Dead body is a 3.
Yeah, dead body's a rock.
A rock's a 3. You don't know that table might be able to do a lot of things when we walk out of here. Table 9 tells you how to check the 12 cranial nerves. You're welcome to look at that. I could ask you on the test if I'm checking, if they're asking about their sense of smell, which cranial nerve is that? 1, because you have how many noses? You have 1 nose. You don't have noses. You only have 1 nose. All right? What about visual acuity? I'm asking if they can see. 2, because I have 2 eyes, right?
So pupil size is 3 because 3.
Because 3 works with, like 3, 4, and 6 all work with eye movement. The constriction and reaction of the pupils, the movement of the eyes. I'm probably not going to ask you one that hard. It's going to be something easy.
Okay, so 1, 2, or 10.
Probably. Yeah, 1, 2. What's 10?
Vegas.
Yeah. Check for swallowing. They shrug their shoulders. Also checking for posture, good coordination. I don't have good coordination on a given day at all. I'm very clumsy. I trip over my own feet, which is probably why I should not wear flip-flops, because to me they're the most comfortable shoes. All right. What's that long P word at the end? Somebody say it for me. Sam? Proprioception. What does that mean? I know if I'm standing here and my eyes are closed, I know where my nose is. Can I touch it? I'm not drunk or intoxicated, so I should be able to. I can't do that. I have very bad balance, coordination altogether. And no, I'm not intoxicated. I can't even walk a straight line. I would fail a field sobriety test and I don't even drink. I couldn't take one. They'd have to let me do a breathalyzer because I couldn't do it. Check for sensation. This is showing deep tendon reflex response. It can be 0 or 4, which means if I tap on my knee, a 4 would be me kicking all the way to the ceiling. 0 would be me not kicking at all. I also check for delirium or dementia. Are those the same things? No. What is delirium? And it's usually acute, right? Sudden onset. What's dementia? Slow, progressive, chronic onset. Usually happens to the elderly patients, right? Who is usually delirious or can have delirium? Mental patients, like patients with schizophrenia. What did you say, Christina? Drug patients that like to take drugs. Drug patients like to take drugs. You like that, didn't you? Secondary assessment of an unresponsive patient. We've already said if they're unresponsive, then you're going to have to do a full secondary assessment, right? If they're responsive and have a localized injury, do you do a full head-to-toe assessment? No, you do a focus assessment, right? We already talked about this. All right, here's your clicker question. How often are vital signs and ABCs assessed in a critical patient? If a critical patient, how often are vital signs and ABCs assessed?
As often as you remember.
What'd you say? You mean you get higher than a, what are we talking about? Higher than an 80? That's a good thing. That's not bad. How did 25 people answer? We've only had 24 the whole time.
And Audra left. Ooh, there's a ghost in here.
There's 28 of y'all, so that would be 25, but there's been 2 people not answering the whole time. That means when I take up your clickers with your number on it and this counts as a test grade, it's only going to be a 0.
Somebody's clicking at work.
Is that what it is? All right, so how often would you assess? Every 5 minutes. Everybody else?
15.
Every 10 to 15. Normally every 15. Critical patients, unstable patients, unresponsive patients, everybody's 5. You have 2 classifications of trauma patients, either an isolated injury or a multi-system trauma. Isolated injury, you're going to do a rapid trauma exam for an isolated injury? No. What about for a multi-system trauma? Yes, they would get a full rapid head-to-toe assessment. High visibility factor, do not get tunnel vision. Do not get, I can't talk today. Do not get tunnel vision. What I mean is if you have an open ankle fracture, don't forget to assess other things. All right, that patient could be having a heart attack, which caused them to wreck, thus causing a femur or open ankle fracture. All right, don't get tunnel vision and focus on one thing because it's an obvious injury. Patients who are unresponsive or have altered mental status are considered high risk. That's a given. Those are considered your critical patients. They're going to need full head-to-toe exams. They're going to need to be reassessed every 5 minutes. For infants and children, try to get the information from the children or the patients. If they're a 1-year-old, are you going to be able to ask them how they're feeling today? No, you have to rely on the patient or the parent or the caregiver, excuse me. Always obtain permission from the parents. You always obtain permission from your patient anyway. But if they're a child, you're going to have to obtain permission from their parents. You always walk up and say, hey, my name's Hudson. I'm a paramedic. Can I help you today? How many of you actually do that? 2 of you? 2 of you that work out in the field actually do that?
Do what? Wait, do what?
I never say I'm a paramedic.
Well, what do you say?
I say I'm an EMT.
There you go. You don't say you're an advanced EMT?
No, people, they get confused when
If
you
you
throw
say
that
that, they're
one
like,
big word.
"Whoa, what is that?" It's not all about having advanced on my shirt.
Because then they probably think that you're better than a paramedic,
Yeah.
paramedic because you're advanced.
He has advanced on his shirt. I know that word. We're gonna go with that.
That's funny. That's like the nursing staff telling me they don't know how to take care or how to educate EMT students. They've had EMT students for how many years? That's kind of,
They do a fantastic job.
they do a fantastic job. These patients you want to examine from toe to the head. Why do you examine your infants and pediatric patients from the toe to the head?
See those.
Physically examine them from their toe to their head. Why do you do that?
They don't get scared.
So they don't get
Because
scared.
you
You
get straight for the
establish
head.
trust. You start at their head, you're going to freak them out. Okay? Establishing trust, working from the toes to the head. Let them be as involved as possible. When examining a newborn or neonate, some things that you might consider abnormal are actually normal. What is Vernex? The creamy cottage cheesy stuff that's over a newborn as soon as they come or delivered into the world. Okay, that's normal, right?
I'm glad I don't like cottage cheese.
All right, what about edema? Like if they have periorbital edema. Is that normal or abnormal in a neonate? Normal. Because why? What's coming out first? What's usually pressed against the pelvic cavity first? Their head and face. All right. What about Mongolian spots? They look like bruises, and it's usually to the lower back side of the butt, or on the bottom, or right up above the bottom. It's usually deals with, I can't think of what nationality usually has Mongolian spots. Is it? But Asians and Indian
Well, my children have.
descent. Your children?
But they're like, my family's all, we're like, all mixed. So they have them, and my daughter's crazy when she had them when she was a baby. They look like really bad bruising, and they would move, around different areas. They come and go. And then now that she's 12, she don't have those anymore. But where they had moved, I watched the one that she had on her back is now here. But it's just a patch that won't tan. Like when she gets out in the sun, this won't tan at all. She's really brown.
My brother has large birthmarks on his arms and his chest and his back. Teachers used to think he was abused when we were kids because they're big, red, and purple.
My sister has a Mongolian spot all over.
I can't tan either, which I have vitiligo. I lost my melanin, which is why I have white and slightly tan skin. I don't tan because I don't have any melanin. My melanin's gone bye-bye. I turn red. I don't tan.
I tan, but I get sunspots on those.
I just lost my melanin. Me and my mother and my brother, all three have it.
Where's it at?
Everywhere.
You know?
Melanin's in your body. That's what makes your skin tan and turn that nice brown color.
He's being pain. He's asking where it went. Where did it leave?
Oh, I don't know. Oh, it ate itself because it's an autoimmune disease. So my body ate up the melanin. I used to have a beautiful tan. I didn't get it till I was 20. I did. Did not get it till I was 20. It actually started out as a spot on my hand right here that looked like a Playboy bunny. I used to go to tanning bed all the time when I was in high school, and they had those stickers, and that's what it looked like. It looked like I put a Playboy bunny sticker right here on my hand, and that's what it looked like at first, and it spread. My brother's had it since he was in the 4th grade, and his is nowhere near as advanced as mine is. My mom's had it. She got it when she was 20, when she was pregnant with my brother, and I didn't get it till I turned 20, which is kind of funny because Jamie's had it forever almost, and I didn't get it till I was 20 years old. I was in college.
Years ago.
Years and years and years ago. My hands used to be, like when I'd go outside, I'd get really tan on the brown spots that I still had where it had first started. So people thought I had been burned on my hands. But now, I don't, this is as tan as I get. I get white or red. So I have to wear like the 100 SPF when I go outside.
And a big old hat.
That's like hot food.
Huh? Yeah.
It's like wearing cologne.
That's why I don't go outside very often. When I do, I have to wear long shirts and floppy hats. All right. Make sure if they are an infant under the age of like 3 months that you're supporting their head and neck because they don't have good control over their head and neck. That usually doesn't come until they're about 3 or 4 months old. If they're a brand new baby, inspect the umbilical cord. Children are prone to dehydrate and prone to infection. They do
bounce back very quickly. Or excuse me, they do, what's the word I'm looking for?
Recover.
They do recover better than adults do. And they compensate for a long period of time. They can compensate for dehydration a lot longer than an adult can, but once they crash, they can be very hard to get back. Ages 1 to 3 years will object to being touched or manipulated unless you have a very friendly child. Annabelle wants to go to everybody. She's not a year old yet, but she will try to go to everybody, and I think she's going to be like that for the rest of her life. Use a toe-to-head approach to build trust. 4 to 5 years are usually cooperative. They have a lot of questions and like to be helpful. They like to know what you're doing, so talk to them on their level. They're also very literal thinkers. Don't tell them I'm going to take your blood pressure because they'll be like, where are you taking them to? Where's it going? School-age children, make sure you explain everything. They're also like 4 and 5-year-olds. They like to be very helpful. They like to know what's going on. They're also literal thinkers. You need to explain every detail that you can. Don't tell them it's not going to hurt if it is. Tell them it is going to hurt. Don't lie. Otherwise, they're not going to trust you to do anything. Adolescents. What are adolescents concerned with? Themselves. They're concerned with their body image, right? They take privacy very, it's very important to them. So if you can, always assess the same sex. Like have a female assess a female adolescent, have a male assess a male adolescent. Also with your adolescent patients, try to talk to them and assess them away from their parents, if possible. You're liable to get more and better information if you keep them away from the parents. General principle, always remain calm. Be honest. Be gentle. Do not be rough with these patients. Don't just throw them on a backboard and you're going to package them and take them to the hospital. You're going to have a screaming, flailing child everywhere. Do not neglect a child's pain. They're telling you they hurt. They hurt. They're not usually just going to sit here and say, I hurt for the heck of it, like some adults do to get attention. Kids are usually, if they're in pain, they're going to tell you they're in pain. Recording your secondary assessments should be orderly and concise. Go by your medical director or whatever your protocol is for your facility. Document objective signs. What's a pertinent negative? Something that should be there but it's not there. Like somebody who's having an active MI, what would you expect them to have? Chest pain, shortness of breath, be diaphoretic. Somebody having abdominal pain, what would you expect to see? Guarding of the abdomen, painful on palpation, maybe even some nausea and vomiting. Possible trauma. So not having some of these things would be considered a pertinent negative. All right. Which one is considered a pertinent negative of a patient with chest pain who is possibly having an MI? Which one of these listed here is a pertinent negative? Think about it. Envy is nausea, vomiting. So pertinent negative is something that should be there, but it's not there. All right, 3 more, 2 more. All right, we're going to go from there. So somebody having an MI, are they going to have a productive cough?
No.
It's not a normal finding, is it? No. What about diaphoresis? That's a normal finding. For somebody having an MI, that's pretty normal. So if it said denies diaphoresis, then that might be considered a pertinent negative.
You really didn't. No, I'm not sweaty. What are you talking about?
No diaphoresis noted is probably what you would say. All right, slurred speech, would they have that with an MI? That's seen with what? Stroke. Nausea and vomiting, would you have that with an MI? Yes. So the correct answer would be C. They deny any shortness of breath. Someone having an active MI, 99% of the time is going to have some shortness of breath. So denying shortness of breath would be considered a pertinent negative. Does everybody understand what that means? Limits to the secondary assessment, you can't perform blood work other than an AccuCheck. You don't have a troponin scale to check to see if they have cardiac enzymes elevated, right? If they have cardiac enzymes elevated, they don't usually get elevated to what? How many hours later? You know? 6 to 8 hours later. Okay? You also can't run a chem panel. You can't tell they're dehydrated. You can't tell, lab work wise, their potassium's elevated, but how can you with EKG?
You're elevated T waves.
Elevated peak T waves.
If you're a flight medic from Children's, you have a blood gas machine.
That is the coolest thing. They have like a jet.
Well, they got that too. But
Thing is
they carry the
massive.
little, I forget what it's called. There's a fancy name for it, but it's like a baby blood gas machine. It takes like a minute. It pops up all your gases.
That's awesome. Maybe one day EMS will carry those things. It'd be good for you to have. All that bouncing around, you have to be pretty trained how to do it. I know some medics and some nurses that have gotten blood from arterial stick, not meaning to, sticking the AC because it's very easy to stick the arterial.
And then some people have put out their brachial artery will pop up in their AC.
Yeah, but that's when you check for pulsations
Well, yeah,
before you
yeah,
stick.
that's
Not a lot of people do.
supposed to.
You're supposed to. There's a lot of stuff you're supposed to do. Nick talked to y'all yesterday about 12 lead EKGs. You know how to put them on?
Yeah.
All right, that's one of the monitoring devices that you can use. We also have capnography that you can do, blood glucose level. Your cardiac biomarkers like a troponin you're not going to be able to do in the field. Other blood tests you're not going to be able to do in the field. What's a BMP? Measures heart failure. Patients that would be elevated in your heart failure patients. All right, what is a D-dimer? Anybody know what a D-dimer is?
It's a test that can test for a blood clot.
Test that can test for blood clots. Usually for pulmonary embolism, it would be very elevated. I don't care that you know that, but it was just a, yes, they can be very inaccurate. Reassessment, you reassess you reassess stable patients every 15 minutes, unstable or unresponsive patients, which are considered unstable, every 5 minutes. Compare loss of level of consciousness with baseline assessment. Always reassess your ABCs. Also reassess any abnormalities that you found in your secondary assessment if you had to do one. Children, that should say, yeah, they do decompensate quickly. They compensate for a long time, but when they start to decompensate, they do decompensate very quickly. Geriatric patients may show no signs of deterioration. When you're transporting your patients, have you addressed all their life threats? Life threats would be anything affecting what? A, B, or C. Life or limb. Okay? Do priorities need to be revised? Is your initial transport decision still appropriate? Obtain another complete set of vital signs to compare with your expected outcomes. Your priority patients, usually your transport time is not going to be most of the time it's not less than 5 minutes, so you should at least have enough time to get 2 sets of vital signs. You'd like to try to at least get 3. Look for trends in your patient assessment. Revisit any complaints they might have. Of course, always document all of your findings. What's wrong with this guy?
He's got a little bit of significant trauma going on there.
Do you have a localized trauma or a multi-system trauma?
Multi-system.
That's the
I think I just got water in my sinus cavity.
Please tell me you started the recording back on this one. Oh my god, that is fantastic.
Okay, multi-system trauma. I got this picture back whenever I did the trauma lecture for nursing a few years ago when I did my graduate degree stuff. Dr. Huff in nursing had this picture. And I told her, I was like, can I please steal this? Please. And she's like, yes. This is a nice little picture. He actually is a guy, I think they said the caption behind it said he was from Minnesota, was riding his motorcycle, lost control, flipped off the motorcycle and landed butt down on a wooden fence post.
There would have been so much force involved in that. He did live.
Yes, he did live.
Is that his backside or is that his?
That's his front side. You can see his jump
He's
right
laying on
here.
his back. That's his wee wee.
Oh,
that's going like straight.
Straight in. He actually had, of course, a crushed pelvis. That's what you see, a crushed
There
pelvis.
was no pelvis left.
There wasn't a pelvis left. He had to have multiple surgeries, lots of rehabilitation, but from what I understand, talking to Dr. Huff when she got the picture and the caption stuff behind it, was that he did live after multiple surgeries and lots of rehabilitation. But it was lodged in there so tightly that he didn't have any problems with circulation. Like no outside bleeding.
Okay, yeah.
No outside bleeding. He had a lot of internal bleeding, but he did not have any external bleeding. Apparently you just had to cut the fence post and lay him down. Yeah, you can tell they had to saw the fence post.
Don't you know that hurt?
All that vibration.
Oh, I would have begged for some sedation. Sedate the hell.
I think they RSI'd him or something because he was intubated.
Yeah, he had to be intubated. I mean, wouldn't you want somebody to RSI you?
Oh God, in that case, well, he was probably. I mean, he would probably passed out from shock.
Oh, I would imagine. I mean, I could not.
You would hope.
There's more?
I could not fathom what. You want more pictures like that?
No, there's more.
Slides?
There's only 27. We can-
This is easy. Yeah, this is quick. This is chapter 14. It's actually going to leave you guys probably with 30, 40 minutes or so to work on your group projects because this is probably the only other class time that you have to work on your group projects. So you really need to be getting in touch with that. And I want to talk to every group when we get done and figure out what you're doing. Okay? We need to talk about what you're doing. We're going to write on the board or something. We're going to figure out what everybody's doing. All right? Critical thinking and critical decision making. I can't teach you how to critically think. I can't teach you how to synthesize all the data that you found, come up with a differential diagnosis. I can teach you all of the mechanics that go into it, the pathophysiology, and the different problems that you can encounter. But nobody can teach you how to critically think. That's a skill that you have to develop on your own. All right? You must be able to identify the problems, set patient care priorities, develop a plan, and be able to execute it. All right? You're walking in. Using your patient assessment triangle, you can tell if your patient's sick or not sick. I'm identifying problems. All right? I'm setting my priorities. Well, they're gasping for air, but they also have bleeding. Which one am I going to do first?
Airway.
Airway, right? I'm going to try to fix their airway and then work on their bleeding.
When do you change your ABCs to CABs? Doesn't that?
That's for trauma patients who have cervical spine
Okay.
problems. You're going to do their cervical spine first, and then you go to airway, breathing, circulation. That's the only time you do that. Cookbook medicine can lead to ineffective care. You can't just rely on, well, this patient's having an MI, so I'm going to go down the list. You're going to have problems if you try to do that. You can't be a cookbook paramedic. You can't just say, okay, well, this is how the recipe goes. This is the way I'm going to do it, because you're always going to have problems. Okay? I like that term, cookbook medicine. You are expected to provide quality patient care. That's a given. You must be able to communicate and obtain information from many types of patients. Diverse age groups, different backgrounds, different education. Some people might think an advanced EMT is better than a medic. But you and I know what an advanced EMT is and what a paramedic is. Lay people, on the other hand, do not. You also have patients who might have consumed drugs or alcohol, which can make them more difficult to deal with. Gathering, evaluating, and synthesizing your data. First thing you want to do is assess and evaluate the data that you've gathered. Okay, grab it all together. Then you got to develop a plan. You got to evaluate it. Figure out what kind of data you've got and what's going on. Be as objective as possible. Evaluate information that you find on scene, from the patient itself, and from any bystanders. Determine what information is valid or not valid. Somebody having chest pain, does it really matter if they've had their tonsils removed? Does it matter that they've had left foot surgery? Is that invalid or valid? Invalid. It doesn't matter.
If they've had foot surgery and then it clotted and then it broke away.
Like foot surgery 10 years ago.
Okay.
It's invalid.
Recent foot
I can understand what you mean. Yeah, any kind of recent surgery is valid to somebody having an MI. All right, here's an example. A 64-year-old man reporting chest pains, has a history of type 1 diabetes since childhood. He is a long-time smoker, and he has COPD. What's he at risk for?
Everything.
He's at risk for having an MI, right? Why?
Because he's COPD, smoker, and he's a diabetic.
He's a smoker, he's a diabetic, so he's got very bad, poor perfusion, right? Not good perfusion at all. He's not getting good perfusion to his heart. What's going to happen? It's going to become ischemic, right? What do I mean by ischemic?
The tissue's not going to get enough blood.
Tissue's not getting enough oxygen. Not enough blood flow, which he's not getting enough oxygen, so the tissue's going to start to die, which is going to cause ischemia, which is going to cause pain, which is going to cause a heart attack. Okay? Treatment plan is guided by patient care protocols and standing orders. What you have on the truck that tells you what you can do. Do y'all have flip charts or anything? Little protocols? When I worked in the ER, when we first developed protocols, back whenever I first became a nurse in the ER, The doctors developed our protocols for the ER, and they gave them out to us on a flip chart thing. It was really interesting. I liked having that in my hands. Most of you have it on your phones, don't you?
We keep them.
Which, in the emergency room, we didn't have but like 6 or 7 different protocols. And it was on a little flip chart. It was easy to have, hold on to. And once you got used to doing it, then you remember what your protocols were. Also, you can call medical direction for anything that's not in your protocols. Yeah, I probably know more about protocols and setting orders than I do. So it's different for the EMS world than it is for the hospital setting. Must recognize and treat immediate life threats. You'll already know that. Thinking and working under pressure. It's very easy to get overwhelmed and get tunnel vision, especially in a disaster type situation. So you've got to focus yourself, breathe, take time to evaluate everything, gather all the information that you can, make a decision, and implement that plan. You have to be able to determine if your patient's sick or not sick. Keep your thinking clear. Working on triage. I've got a lot of medics coming to help us with the disaster drill. We're going to do a lot with triaging. We haven't decided yet what the disaster drill is actually going to be. That's on April 17th. Half of you will report into the lab and half of you will report in the classroom. I believe Miss Curry's teaching on Tuesday, and Nick's teaching on Wednesday.
Oh, that was the shorter textbook. Where we're split.
Oh, that's right. I'm so sorry. I need to go home. My brain's not working. I apologize. Sorry. Thank you, Hudson. Children's Expo is April 1st and 2nd, that Tuesday and Wednesday. Half of you are going to report here, another half of you are going to report down in the lab. For disaster drill, everybody will be here. You have to be here at 8. If you remember looking back at your calendar, you need to be here at 8 for us to get started. Range of critical patient conditions. You have your critical patients, your serious patients, your life threats, non-life-threatening injuries. You'll already know all this. Concept formation. First thing is the first stage in pre-hospital care. You gather all your information. Some of this stuff is redundant, I know. Begins as soon as you arrive on scene. You're looking at the scene, then you're looking at your patients. Primary assessment identifies any life threats that you need to fix. Then you move into your secondary assessment, vital signs, gathering all your data. Once you've gathered all your data, you're going to apply it. So you evaluate. You're looking at everything, and you gather all your data, your objective and your subjective data. Then you apply it. You fix life threats immediately, then move on. Fourth step is reflection. What is reflection? What do I mean by that?
Going back on you, or looking back.
Looking back over it whenever you're at the station doing your report, thinking back on, well, maybe I should have done this differently. How could I have helped the situation? Reflection really works good, especially in trauma arrest, cardiac arrest, or respiratory arrest. Helps you remember, okay, I did all this. What could I have done better? What could I have done differently? Elements that contribute to your critical thinking. You need to be able to have knowledge about the scenes themselves, be able to organize data, be able to interpret the data. You get a low blood pressure or low oxygen level, low glucose level. You need to know what that means and how you're going to fix it. Each call is very unique, has their own unique circumstances. You have a checklist for performance. You're scanning the situation, stopping and thinking about what's going on. Make sure that you are staying calm. And staying calm, especially in a disaster, is most important. The 6 R's help to sum up critical thinking. First thing is read the scene. What are you looking for? Overall scene safety, right? Environmental conditions, anything that's going to hurt my patient or make problems for myself. Also looking at mechanism of injury. Read the patient. So I'm reading my scene. Next, I'm reading my patient. Checking my ABCs, looking for any life threats, treating those. I'm reacting, taking care of my life threats. I'm reevaluating, follow up on any interventions that I might have done. Making a plan, using a working diagnosis. I've treated any life threats. Now I'm looking, my patient's having an MI. What am I going to do? What plan am I going to have? And then lastly, I'm going to review my performance.
Oh.
Isn't my daughter cute? Isn't she pretty? Her little red cheeks. I thought you needed a happy picture since the last time I gave you pretty nasty. That's it. That's it. I told you that one was easy because you've had a lot of information before, and I really can't teach you critical thinking.